Okay, for this week in Module 3, we'll be discussing the NICU, finishing up discussing of the components of that, and then we'll move on to the pre-linguistic infant components. And for next week for Module 4, we'll close out Chapter 6 with talking about the pre-intentional infant and special populations and autism. So let's get it started with the the NICU child. So in the NICU, we've already discussed swallowing, oral feeding, and vocal development. So let's discuss hearing conservation and oral habilitation. And remembering that habilitation is, of course, rehab. It's whenever we're trying to recover something. When we're in our practice, we're looking to habilitate, which means, sorry, got a text about Kennedy. We're looking to habilitate, which means to treat something that's always been there. So 44 states mandate hearing screenings for all newborns. And Mississippi does do that again. I think I've mentioned it before. We were one of the first states to do that. The NICU can present a hearing hazard, however, that some studies have found that the NICU can reach decibel levels of up to 85 dB. So that could result in a hearing loss just from being in that NICU environment with all those loud noises around them. In addition to that, the syndromes and conditions that warrant NICU stay have a high incidence of hearing loss. So we must be very aware of these syndromes and diseases, disorders that cause hearing loss, and when hearing loss can be tied to a syndrome or a condition. And if the child was not identified initially at the infant newborn hearing screening, there is still potential for hearing loss perhaps later in life or something that wasn't initially identifiable. So being aware of that and counseling others to be aware of that. So the SLP, you make sure that oral habilitation is part of the management plan in the case of hearing loss. And you can encourage the parents to have the hearing tested periodically through the child's early years. I think it suggests that every 3 months for the first year of life for these children who are at high risk, particularly for those newborn children who might have been born very early prior to 32 weeks gestation when the hearing wasn't necessarily fully developed yet in the womb. Okay, so let's look at NICU child behavior and development. So in each section it's broken down by assessment and management. So the assessment of the child's behavior and development in the NICU, our purpose here is not to predict future behavior, but to determine the current strengths and needs, which makes sense. I mean, that's what you would be doing in any other situation to know what the child's strengths and weaknesses are right now and identify that so that you can treat it. But some parents might be thinking, or other professionals might be thinking, that we're trying to use the assessment to predict whether or not this child will forever have a speech and language deficit, and that's not the case. We're just trying to address what's presenting itself. If we assess and we see that there is no need for intervention at this point, then that's okay, but it's still our job to continue to help monitor and educate others about how to be aware of those communication needs that the child might be present with at a later point in development. So there are 2 components of what you as the SLP needs to know. First, it's important to know as much as we can about the risk the infant faces, and that means the infant's medical condition. The knowledge of this can help us decide how much and what kind of intervention to propose. So say, for instance, you have a child for Down syndrome. The book uses the example, we know the risk for future speech and language delays as well as mental ear dysfunction is high. So we can argue for stronger earlier communication intervention than we might in the case of a child with prematurity alone. So knowing what's involved in the conditions that we're seeing in the NICU is very critical in knowing what kind of recommendations to make through the plan. Secondly, we need to evaluate the infant's level of physiological organization, the extent to which the baby can maintain physiological and attentional states. Premature infants experience irregular respiration, they have color changes, body instability, including jitteriness and flaccidity, and disorganized patterns of alertness. So if they cannot become physiologically stable, then they're not going to be ready to have those communicative interactions happening. So until they're physiologically stable and able to maintain those alert states, the communication's not going, that two-way communication street's not going to be happening, which makes sense. Again, if the infant's not alert and not looking at the parent, it makes it difficult for them to interact with each other. Now, there are formal assessments available for NICU babies ages 28 to 40 weeks gestation, which can identify conditions under which the baby functions best, what stresses the baby, how much handling stimulation the baby tolerates, how easily the baby's homeostasis is disrupted, and homeostasis being that best alert state, like basically the child is stable and not subjected to those the irregular respiration, disorganized patterns of alertness, jitteriness, flaccidity, all those things we talked about before. What helps baby with self-control and the endurance the baby has for interactive functioning. And the book lists the assessments: the neonatal behavioral assessment scale, neurological assessment of the preterm and full-term newborn infant, naturalistic observations of the newborn, assessment of preterm infant behaviors, assessment of preterm infant behavior, developmental and therapeutic interventions in the NICU, and the NICU network neurobehavioral scale. So those are all formal assessment procedures that are available. And they might not be done by you, the SLP, necessarily. They could be done by the physician or by one of the nurses. The SLP can review the results for the information that will help in planning for the communicative intervention program. So these aren't necessarily assessments that you're going to be conducting. There's more for the staff in the NICU area, but you can still use the information for those assessments to help guide and manage the program for the child. So management, what is our management for this child? We want to achieve stabilization and homeostasis of physiological and behavioral states and prevent or minimize any secondary disorders that might be associated with the child's condition. And again, those secondary disorders could be such as hearing loss. So we're not trying to help them attain milestones appropriate for full-term babies. We want to stabilize them in their present state that they are. The best way to do this is become a member of the NICU team, earn respect of the medical staff. These are strategies to help us provide, advocate for the developmental and supportive care that uses strategies. So these are things that we can do to help manage that. We want to encourage careful monitoring of noise levels and infant hearing, to help prevent any potential hearing loss from decibel levels that are too high within that NICU environment. We want to develop staff awareness and dangers of ototoxic effects of medications. So some specific medications can be ototoxic, meaning they're going to cause hearing loss. So we want the staff to be aware of those potential medications. Foster sensitivity to laryngeal damage from endotracheal tubes. So that's what we talked about before, about those, not the oral stimulation. We want to desensitize the child to anything in their mouth because they have that hypersensitivity to having anything in their mouth because they had a trach. When we want to alleviate sensory overstimulation because of the constant bright light, they never have a dark environment or a quiet environment, so they can become overstimulated. So we want to decrease the sensory overstimulation they might be experiencing. Suggest ways to counteract low language and interactive stimulation that results from infrequent handling. So again, these infants might not be handled very frequently, so we want to counteract that. Maybe the kangaroo care, which is mentioned a little bit later. They have that skin-to-skin contact. Other ways to help manage that infrequent handling that happens as a result of the child's medical fragility. You encourage consideration of the oral motor consequences of continued use of the NG and Gavage tube feeding, which bears in mind the surgical risk for the G-tube feeding entails. SLP can help families and medical staff to work together to consider how the risks can be balanced. Advocate for the importance of non-nutritive sucking and oral stimulation, which again the articles last week or 2 weeks ago supported that. Educate staff about the efficacy of early intervention. Provide info about services offered by other disciplines such as occupational therapists, physical therapists, use the SLP counseling. Support parents in achieving their goals for their child during the NICU stay. If that goal is just simply that the child leaves there with oral feeding, then you help the parent achieve that goal. And again, remember that oral feeding was one of the discharge criteria for the NICU. Encourage parents to talk to, touch, and hold the baby and help with positioning. And help parents recognize, understand, and interpret the infant's signals. Help time caregiving and interaction to promote the infant's state regulation, allow for natural sleep-wake cycles. So all this we're going to talk about in more extent a little bit later about how to know the infant's state of alertness and what the best time and the ideal time for infant and parent and child interaction is to incur. All right, so from that assessment of their behavior and development, we move into the parent-child communication component. So we know where they're performing with their behaviors. Let's move into what the parent needs to do to help communicate with that child. We know that infants are at risk for communication deficits due to their medical conditions and neurological immaturity. So we need to assess where they're performing, again, their strengths and weaknesses, not trying to identify the future outcomes, but what's happening with them right now. So we could use instruments to formal assessments such as the APIB, which will help identify the level of interactive, motor, and organizational development that the infant in the NICU is showing. We want to there are certain states that the infant needs to present with for us to know whether or not they're ready for the communication and the parent-child interaction. So Brazelton defined 3 stages of behavioral organization in high-risk newborns. They are turning in, coming out, and reciprocity. Turning in, which is also known as the physiological state. This state is when the baby is very sick and cannot really participate in reciprocal interactions. The baby's basically turned in, turned away, just trying to survive right then. In the coming out stage, the baby first becomes responsive to the environment when he or she is no longer actually acutely ill, can breathe adequately, and begins to gain weight. It usually occurs when the baby is still in the NICU, and it is when he or she can begin to benefit from interactions with parents. So that turning in stage, even though the child doesn't necessarily benefit from the interactions with parents, we do want parents to still interact with the baby at that point if they're able. Sometimes the parents can't physically touch the baby because of the risk to the baby, but as much as possible that allows with the child's medical condition, the parents need to be interacting with that baby even during the turning in stage, even though the baby doesn't benefit from that, so the parents can get used to interacting with their child. But the coming out stage is the critical stage that the children have to reach for the interactions to begin. And then reciprocity is the final stage, usually occurs at some point before the baby is released from the hospital. The infant can respond to parental interaction in a predictable way. Failure to achieve this stage is a signal that developmental deficits may persist. So we want to see the reciprocity by the time they're leaving the hospital, if it's possible for that infant. And usually we do. I saw it with my own child when he was born, when it's just, even if it's the child cries, the parent picks the child up, the child stops crying. That would be considered a reciprocal event. So you want an important role use the SLP can serve is to acquaint the parent with this progression and how to be tuned in to their infant when they're in that coming out stage or reciprocity stage. Okay. Then for parent communication and family functioning, how do we assess that? So we've assessed the infant. Now we're going to look at what the parents and the family are doing. Formal instruments are available to assess parent-child interactions, the behavior progression, which a clinician with guidelines for observing parents' behaviors with the infant to assess the parent's needs in order to improve or maximize the value of interactions. You also have the observation and communication interaction, newborn behavioral observation system, and parent information relationships global assessment. But we don't want to convey to the family in any way that we think they're the problem. Infants should be used to guide us and the parents and the family as a whole together on what areas we need to enhance, if any, for the most ideal parent-infant interactions. So sometimes, though, the unspoken implications to the family members is that they have a problem that needs to be assessed when you have that formal assessment done. And they've also found that the most threatening aspect of early intervention for parents of handicapped children is the assessment of the family. So the best way to prevent the parents from being threatened by this assessment component is to simply develop a relationship with the family, just like we would in any kind of other situation when it's therapy. If we don't have a relationship with the child, with the parent, with the people we're working with, and where we have a good rapport established, we're not going to make good progress within those therapeutic goals. So sometimes instead of taking all that time to do the extensive formal assessment of a family, you can better spend your time developing a relationship with the family and giving them the opportunity to talk at length with the clinician about the frustrations and joys of raising their baby, because they're completely overwhelmed at this point with all that is happening with the child. You're overwhelmed as a parent with a typically developing child, a child who's not been in the NICU or at risk and doesn't have all these occurring medical conditions in addition to just being a parent. So sometimes just listening to the parent allows you to establish that relationship and that rapport. There also is a family interest survey, not to evaluate the family, but to simply find out what they think about their child's needs, which could be used to identify areas of the family's interest in both intervention goals and social services. The How Can We Help survey is a similar instrument. These appear in Appendix 6.5. So our goal is to support the family, give information they need when they are ready, and responds to the family's needs. So, our role as an advocate and an ally is the most important role to preserve. So we want to find out their priorities, what they feel is most important to them with interacting with their child. And this is the whole idea of family-centered intervention happening in early intervention services. Um, so it's just, I like the way they close this section of the paragraph. It's a simple a family-centered approach involves not a complicated psychology, but rather a simple human attempt to treat others as we would wish them to be treated if we were experiencing a difficult transition that the NICU infant's family must face. So we really just need to have the most empathy we can for them, trying to put ourselves in their situation about how overwhelmed they must be feeling, dealing with this, all of the complexities of this child that they've now have to bring home after leaving the NICU environment. So in management in the NICU setting, the parent-child communication. I mentioned before the kangaroo care. This is skin-to-skin contact and opportunities for parent-child interaction that should last about 30 minutes per day. The child gets swaddles in the next to the parent's chest with skin-to-skin. So, mom maybe drops her shirt down or open. Dad doesn't have a shirt on. Baby is just swaddled in that. The baby just is covered with a blanket. Chest-to-chest contact, skin-to-skin contact. The baby can feel the parent can feel the baby. This helps develop that relationship between the parent and the child on both ends, because the parent needs to feel a bond with that child as well as the child with the parent. Another thing that hospitals do, even when you have a newborn child, is almost immediately after birthing the child, they give you that baby, especially if you're going to breastfeed, to your breast right away to feed before they clean them up or anything. They take them out and put them on the scale, do the APGAR, see what the rating is, 1 to 10 scale, and then they take the baby, hand it to you, okay, feed, to establish that immediate relationship to the mother, to the pleasure that oral feeding provides, and that skin-to-skin contact of that mother to that baby, because those babies are overwhelmed coming into the world as well. But sometimes babies are too unstable to interact because they're very sick, and they can't take advantage of these interactions. We can still encourage the parents, though, to learn to observe their baby states and where communication is possible. So in table 6.1, it lists certain states for babies' interactions. Babies are only receptive to interactions in certain states. So your state 1 is deep sleep. Of course, they're not going to be very receptive. That's when you pick their arm up and they drop it right back down real fast. Deep sleep, they're not going anywhere. Light sleep, however, is when you pick their arm up and they kind of lower it back down, but they don't really wake up. If I have a sleeping baby on my lap, I could demonstrate it to you, because you can tell the difference between deep sleep and light sleep, and the behaviors are described there. Now, drowsy, you can tell when a baby's drowsy when they're kind of drifting off in and out. They get drowsy often when they're feeding. James rubs his eyes a lot, starts crying a little bit more when he starts to get drowsy. Now, quiet alert. There's little bodily movement. Eyes are bright and wide. Face appears bright. Breathing regular. Attends to environmental stimuli. This is when you want to provide something for the baby to look at, listen to, or suck. May maintain this state, which is ideal for interaction. So this is the best state for interaction with the child, the parent-child interaction, and where learning is going to occur. So you want to train parents to look for that quiet alert stage. And James on the videos, and Mason not so much because he was a little bit older, but in James you could see how he was quiet, listening, and then talking. He was in that quiet alert stage. Active alert, and you can tell when James is in active alert versus quiet alert. And of course he's a little bit older, so my examples for him right now aren't as good as they would have been whenever he was 1 month old. But in active alert, there's much more bodily movement. Eyes are open and bright, much facial movement, breathing irregular, increasingly sensitive to disturbing stimuli. Parents can cuddle and console to bring baby to a less aroused state. So this is when they're on the cusp of crying, pretty much. If James is on the floor doing tummy time, he's happy, he's alert, he's playing, and then he sees me, he looks at me, and his face starts to grimace, or maybe he looks at me and he starts kicking and moving his legs and his arms. And of course he's not crawling yet, so he can't get to me, so he's becoming a little bit more agitated that he sees his mom, but he can't get to his mom, or I'm not picking it up, but he's not crying yet. So that's how I would define active alert for him as an example. And then, of course, crying, increased motor activity, color changes, eyes may be tightly closed or open, facial grimaces, breathing irregular, highly responsive to unpleasant stimuli. So when the child reaches this, the child's reached his or her limits, needs to be fed or consoled. And I can, in James, there's a difference between active alert versus full crying. And active alert, he might be a little fussy getting there, but when he's crying, he won't be consoled with a pacifier. He won't. He wants nothing but to be picked up and held and comforted. So in the crying stage, there's absolutely no interaction happening. We experience that sometimes when we're in the car seat on a long ride, and he gets to where he's done. He's not sleeping anymore. He's ready to be picked up and held and played with or something. So you can definitely train the parents to be aware and alert to all of these different stages and states of their child. So we want to facilitate the parents' identification of the infant state by encouraging them to observe their babies and by talking with them about what they see. Once the infant is in the coming out stage, our most important job is to get parents to start communicating with that baby. So we want them to communicate with them when they're in the quiet alert state, not in those other states that we've mentioned. Okay, so to encourage the parents to interact with their child in the coming out stage, we encourage them to look at, handle, talk to, sing, and show things to the baby during the state. And we also want to help the parents identify when the infant can no longer interact and allow the baby to recoup his or her resources that further interaction will be possible later. We don't want the baby to come in and overstimulate them with our interactions. Oh, she's so cute. She's so cute. Oh, that's a happy baby. That's a happy baby. You can tell when the baby reaches their point of, okay, I'm tired of interacting with you. I need to do something else, which might be to sleep or to eat, because that's typically the only thing they're doing. And usually, so take James, for instance, and when he was born, particularly in those first few weeks of life, he had that active alert, that quiet alert stage rather, for probably only about 10 to 20 minutes during between feedings. And he fed every 3 hours. And so if he was not quiet alert or active alert or crying, he was asleep. And most of the time he was asleep. So babies are sleeping so much during that initial first few weeks of life anyway, that there might be very small windows of this quiet alert time. And so that means that they're only going to take so much interaction before they become overstimulated and need to recoup and do something else. So making sure parents are very well aware of what the child can tolerate within that environment. So the parents can be helped to identify infant signs of stress, such as averting gaze, turning the head away, spreading the fingers, arching the back, grunting, and help parents know this is a natural part of the baby's transition from one state to another. The parents need to be aware of all these states because babies naturally move through all these states regardless of their medical conditions. And so we also know that another way that parents can interact with their baby and maybe increase parents' role with the newborn in the NICU is to encourage the parents to participate in charting the child's behavior. And the SLP can discuss this option with other staff and try to make them understand the advantages of listening to parents' help and the big job of keeping the copious records required in the hospital. So the parent can chart, wet diaper, bowel movement, slept 8:30 to 9, bottle at 9, all those tedious little charting that must be occurring in that NICU environment. So it helps the parent feel more like a part of the baby's care team, but charting can help them learn to be better observant of the child's behavior, a skill that will serve them well once they bring the child home. Okay. So in this next session, we're going to discuss assessment intervention for pre-intentional infants. This covers ages 1 to 8 months. So my James is still in that stage. Mason, my nephew, that you observed in the video from this past week's discussion, at 10 months, actually it was 11 months this week, is no longer in the pre-intentional stage. He's moved on to the next stage of being a pre-linguistic infant. And James is even showing signs of being a pre-linguistic infant with some of his communicative interactions. So, but right now he's still very much a pre-intentional infant in that 1 to 8 months, the latter part of the pre-intentional infant being 6 months old. 7 months, sorry, he's 7 months now. And so we'll discuss what that entails. This pre-intentional infant is a phase in which they have not yet developed the cognitive skills to represent ideas in their minds and pursue goals through planned interactions. It's also referred to as the perlocutionary stage, and I know we discussed that in our language disorders class. The infants don't intend an outcome by their behavior, but the adults act as if they do have interaction. And you should recall that everything's about intent, intent, intent when it's us working with children and communicating with children. So even if that child does not intend to have a reaction from us through that communicative behavior, we act as if they did. We act as if they meant to do that. Because this lays the basis for communication later in the first year of life. Okay, so we're going to move now from skipping over feeding and vocal assessment, because we already discussed that last week, to hearing conservation or oral habilitation. And so hearing should be evaluated by an audiologist every 3 to 6 months during the first year of life for the high-risk infant. Parents should be counseled to be aware of the signs of otitis media as well, such as pulling on the ear or jaw, fever, or unexplained fussiness accompanying a cold. Now, I had my first child, Kennedy. She had 3 ear infections within 3 months, 2 non-responsive to antibiotics, so she ended up getting tubes by 11 months of age. Everything was resolved. Her only symptom ever was fever. She never pulled on her ears. She never did a lot of head shaking. She wasn't really fussy. Cecile never had ear infections, and James has it. My nephew Mason also had to have tubes by the time he was 7 months, actually. And his sign was that she picked him up and he would just arch his head back, arch his back, and arch his head back extremely far and just shake his head because his ears were bothering him so bad. So there are other signs besides ear pulling. I think Cecile was a big ear puller, just pulled on her ears all the time, but she never actually had an ear infection. So sometimes those signs can be indicative of an ear infection, sometimes not. You just kind of have to watch and see, and the only true sign is to go in and get them to look at that through the otoscope. But those are some things you can tell the parent to counsel them about how to look for signs of otitis media. It should be treated early and aggressively, and I was very aggressive with the pediatrician about Kennedy getting tubes when she got tubes, because I said, I know that consistently she's not responding to antibiotics, and have consistent otitis media. It's recurrent, 3 within a 3-month time period. Those were all indicators that tubes were necessary over the continued antibiotic treatment, not to mention all the negative side effects of constantly staying on an antibiotic. For children identified with hearing impairments, the use and maintenance of hearing is crucial. So making sure that those hearing aids are worn, maintained. A lot of that has to do with parent counseling. And then for those who need to be good candidates for cochlear implants, consideration for that. So some criteria for good candidates. They're at least 8 to 12 months of age. They have profound hearing loss in both ears. They receive little or no benefit from hearing aids alone. They have no other medical condition that would make the surgery risky. They have good family support system that are involved in all aspects of the informed consent process, understand their roles in successful use of cochlear implants, have realistic expectations for cochlear implant use, and are willing to be involved in intensive rehabilitative services. And they also have a good educational support from their education program to emphasize the development of auditory skills. So with all of these factors, if a child hasn't received a cochlear implant before 2 years of age, that has been shown to promote the efficient acquisition of expressive language, as well as receptive language and speech intelligibility. It's almost no difference between them and a typically hearing child. Okay, so in the pre-intentional infant, let's look at child behavior and development. For assessment of the child behavior and development, again, our goal is to identify the current strengths and needs, not to forecast what the child's going to need in the future, not to predict future status. There's a variety of instruments available for assessing early development: the Bailey Scales of Infant Development 3, the Mullen Scales of Infant Learning. Those scales sample behavioral and cognitive, language, motor, social, emotional, and adaptive behavior. And I mentioned last week that those are the areas we're looking at, developmentally speaking. They also have some parent-informed report type of information, such as the Vineland Adaptive Behavior Scales too. And there's also the Denver 2, a direct assessment often used by pediatricians in their offices to assess development. Appendix 6.3 lists the variety of formal assessments that are available. And then there are instruments that are used that are specific to communication. They're found on table 6.3 on page 198. So you'll see assessing linguistic behavior, assessment, evaluation, and programming system for infants and children, the birth to 3 assessment intervention, British picture vocabulary test, clinical, linguistic, and auditory milestone scale, communication and symbolic behavior scale, early language milestone scales. MacArthur Bates is probably the one I'm most familiar with, communicative developmental inventories, pediatric language acquisition screening, the real, the receptive, expressive, emergent language test scale. I believe one of y'all will be doing that in y'all's presentation. The Rossetti infant and toddler language scale I'm also familiar with. And then the sequence inventory communicative development. So those are a variety of formalized assessment tools that you can use. In addition to general developmental assessment instruments, several instruments are just, I said that, look at communicative and vocal behavior. All right, so for children that are behind age expectations, a general stimulation program to enhance motor and cognitive development may be initiated in collaboration with the team. So essentially you assess them, they're not at the, performing at the age that they should be expected to perform based on either their chronological age or their gestational age or adjusted gestational age for in case of premature babies. So you implement a program to stimulate motor and cognitive abilities. Okay, so that was the assessment component. Now the management of child behavior and development. Again, it's a team effort focused on the family and child. It can be center-based for SLPs address swallowing and communication within that environment. So that's why center-based with infant stimulation programs place a baby in a setting with other handicapped or at-risk infants. An example that comes to mind is the Children's Center for Communication Disorders at DeBarge School. Would be a very family-centered but yet a center-based approach to therapy. But most services for infants at this stage will be home-based, which yields highly positive outcomes, as the research has suggested that this is a very effective means of being able to help children progress through these stages. So it can be interdisciplinary or multidisciplinary approach. The SLPs visit the home themselves. In a transdisciplinary model, the SLP may provide information to another professional to provide the service to the student. If this aspect of the intervention is lost, it can become a lifeless experience. So we want the SLP to be the counselor and the primary person driving that. This is how we interact as humans. And so we want to remind all involved that babies develop within the context of human communication, and that this is what makes interest into the human community possible. So we don't want, if we, in the transdisciplinary approach, if we give somebody things to do with them, we want to make sure it's not very rote and robotic and automatic and not unresponsive to the child, because we want it to be very responsive to the child, especially when the child begins to communicate. Another important function the SLP can fulfill is as a service coordinator and parent advocate. And this is because, again, most parents are so overwhelmed when they come home and these highly needy children. So you come home and the nurse says, be sure to give her a medication on time every time. The OT says, do these exercises so many times a day. The PT says, do these exercises so many times a day. Use the SLP are going, be sure to talk to your baby all the time and make sure that they're here interacting with you and respond to it. So this parent is just inundated, overwhelmed with all of the advice and goals that she's been given to manage for her child. So the SLP can make it, put it all into context for the parent. We help parents sort through the advice from various providers, maybe develop a schedule for the baby and the parents for delivering therapy and medication, even setting a schedule about, okay, the child wakes up, they feed, then we do this between feeding and nap time. Nap, okay, wake up, feed. Maybe there's a diaper changing set into there because the parents might need certain reminders to change their child, even though it might seem like the first thought when a child is crying. When they're that overwhelmed, they may not be thinking of even the most simplistic types of tasks. So, visual organizers. If the baby cries, check this, check this, check this. Help the mother seek support for her network of resources, including family, neighbors, and friends, to get her through the difficult first few months. And then most importantly, SLP can remind the mother what the baby needs most is the same thing every other baby needs: to be loved and played with. And the baby needs a family that is healthy and rested. So the mother's rest is just as important. If that means skipping a baby's exercise once in a while so mom can take a nap, there's nothing wrong with that. There's always tomorrow. So that's a very important component of what we can do as counselors in helping these parents deal with all of these overwhelming tasks that they've been given with these highly needy children. Okay, so in the pre-intentional infant, let's look at the parent-child communication aspect of it. So for assessment, there are various formal assessments that are available: parent-infant relationship global assessment scale, parent behavior progression, observation, communication, and interaction, parent-child play scale, parent-child interaction scale, caregiver scale of interaction. But again, that can be very intimidating and not necessarily sort of the best relationship between the SLP and the parent if the parent thinks that you're judging everything that they're doing and how they're interacting with their child. So there are options to informally assess parent interactions. And if you choose to do an informal assessment, this is what you're looking for. And these are all components that are also included in the formal assessments. So these are what we want to see whenever a parent and child are interacting. We want pleasure and positive affect. So, that they're smiling at the baby, they're cooing and oohing and awing. Responsiveness to the child's cues of readiness and unreadiness to interact. They're not trying to interact with the baby when he's showing the alert stage and not the quiet, the active alert stage and the crying stage. They're responding to that, saying, okay, this is not the right time to interact with the child. They're waiting for the quiet alert stage to go in and start talking to that baby and try to interact. They have acceptance of the baby's overall style and temperament. So they understand this baby's laid back, that he might not interact as much as this baby who's a little bit hyperactive and wants to be interacted with all the time and very demanding of your attention. You're looking for reciprocity and mutuality, the degree to which the parent and infant seem to be tuned into each other. You want appropriateness of choice of objects and activities for interactions. Of course, we want all of these objects to be safe, activities to be appropriate for the baby. Choice of activities and objects that interest and engage the baby, such as those repetitive games, pea pie and patty cake. You're looking for language stimulation and responsiveness, the degree to which the mother talks to the baby appropriately, engages in back and forth and choral babbling activities. So you saw me in the video last week imitating James. He would go, yeah, yeah, and I went, yeah, 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 and then he would go back and do that. So that back and forth choral exchange. Encouragement of joint intention and scaffolding the baby's participation, the extent to which the mother is effective in directing the baby's attention to objects of mutual interest and the way she evokes progressively more elaborate responses from the baby. So shaking the rattle, and both the baby and the mom are looking at the rattle and shaking it, and then as the baby progresses, shaking the rattle, and the baby reaches for it, and then bringing it a little bit further out of the baby's reach, so the baby has to reach further to grab it. So that would be an example of scaffolding. So establishing which aspects can be improved with the parent are the basis for the intervention program, and y'all should sit down together and do this. We must show respect and appreciation of the parents' attempts to get through to the child. And so if we behave as if we know better than the parents how to interact with this baby, we'll be undermining rather than supporting them. And our primary goal is to support the parents. So it's very important we come in non-judgmental and not be condescending with these parents. So it's important to know that even normal parent-child interaction may not be optimal. It's always possible to intensify and increase the frequency of parental input, even when the parent's doing everything right. So all of these things are appropriate, but this is a child that's at risk or is deficient in some way in some area. So even a normal interaction with a parent and child is not enough for these types of children, and that parent who's doing everything right may need to do a little bit more, may need to intensify what they're doing with their child in regards to parent-child interaction. And then you want to use the data from the assessment to help identify with the parent aspects of the intervention that can be enhanced. Because remember, our parents are partners in providing enhanced communicative environment. Okay. So for the management of pre-intentional infants parent-child communication, once we've established what the assessment areas that we need to work on and establish those areas of focus with the parent as communication partners. So intervention in the parent-infant communication involves three aspects. It's make parents and other caregivers aware of the normal communicative patterns of infants and how to tune into the baby's communicative capacities. Provide instruction and modeling of adult-infant communication. And third, to help parents develop self-monitoring skills so they can evaluate and modify their own performance. So we'll look at each of these areas. But first, the awareness of infant communication partners. So the researchers found that mothers tend to respond more with babies who smile and vocalize more often. It's a lot easier to interact with that child when they're giving you back that response than it is when they just sit there and they don't do anything. And that's firsthand experience that I can say that's absolutely true. So initially, if the parent seems unresponsive, it could be because the baby didn't initially respond and her earlier communicative intents have been extinguished by a lack of response from the baby. So you have to come in and reinvigorate communication, so to speak. You want to come in and acknowledge the difficulty communicating with a non-responsive child, and be sure to have that open communication and respect for the parent. And remember that your nonverbal communication speaks as loudly as your verbal communication, so we don't always have to say out loud that we blame the parents, but an unspoken censure can be perceived by parents. If we reassure them and not explicitly and repeatedly that we know that communicating that with a baby can be hard, that's our way of acknowledging the difficulty communicating with a child. And when I help them create to provide a mutually positive communicating environment for parent and child. So by doing this, we can help parents become aware of basic interactive patterns of pre-intentional infants, and the basic development of pre-intentional infants, and that's available in appendices 6, 7, and 6, 8. Sorry, appendices. So these are some training resources that have in Appendix 6, 7 about videos that are available, programs that are available to help train parents. 6, 8 are videos for training parents. 6, 7 are training resources and programs. So helping parents become aware of the basic interactive patterns of pre-intentional infants involves direct observations or videotaping. And if that is not an option, the SLP can provide specific information about the communication to the infant's family by doing some observations and giving them feedback. We want the parent to know that the infant, in this case, does not choose how to interact. The parent is the adult, naturally, and the parent has a choice about how to interact with that child, but the infant only has one way of interacting. They don't have a choice about whether they're smiling or crying. This is their only way to communicate at this point. So the pre-intentional infant doesn't mean to be naughty or bad, and so it's important to communicate to the parents. This is the only way this child has to communicate right now, so it's up to them as a parent to choose how they interact with that child. They need to know that they are the ones who need to adapt for their interaction to succeed. So if the interaction is not working between the parent and child, the parent's the one that needs to change, not the child. Second, the parents need to know that the most important thing they can do for their babies is to enjoy them. So if they're having fun and the baby's having fun, then that is the optimal environment for that communication and interaction that takes place. If they like making silly faces, let them make silly faces. Kennedy is always the one that gets James to laugh, so we use that as opportunities for communication and interactions with James. When his sister comes in and laughs with him, or Cecile comes in and laughs with him. So that it's important to find what that baby enjoys and capitalize on that as the communicative intent, even if it's not necessarily what the parent chooses as the optimal communication between parent and child. So that's what it means by the most important thing they can do for their babies is enjoy them. Finally, the third thing we want parents to know is that communication that enhances development has two major characteristics. It is enriching and responsive. That means they interact with their high-risk babies. Parents should think about providing visual, auditory, and tactile experiences that engage the baby's attention and allow the child to explore novel stimuli that have been carefully chosen for safety and interest. So giving James a ball, giving him a rattle, giving him a teething toy to explore tactilely, visually, auditorily. Anytime he gets something, he smacks it down on the ground, see if it makes a noise. He mouths it and kind of gnaws on it. Today I gave him a rice patty for the first time. And they're hard in your hand, but when they hit the mouth, they dissolve completely, and he can practice chewing on it. So he can in his mouth, and he gnawing, and then it's just crumbling and falling apart. And you can tell he's playing with it because he's pulling it out in his hand, because as it gets wet in his hand, it starts to crumble, and he's looking at it going, it feels different. So that's a way of that, how he's exploring and learning. So that's how they can be enriching, because you're providing all those different stimuli. They also need to attempt to make their interactions responsive to and contingent on what the infant is doing. Some parents might need to be educated about the impossibility of spoiling the pre-intentional infant. So you hear that if you hold a baby too much, you'll spoil them. That is not possible at this point. That is why I embrace the idea of holding them as much as I can, especially at this time, because they grow up way too fast, and that period of growth happens so quickly that they grow out of that being held rather, and cuddled and just loved on. So you need to know that being consistently responsive to the infant's cries and moods at this stage can only enhance development. So if the baby cries, you pick them up, you cuddle them, and they stop crying. That's a way of communicating to that infant that the cry gets them what they want, which is to be comforted and held. So it's important that the parents understand that if a baby is giving them an indication that they don't like something by crying, that they try to respond to it and comfort the baby. So the second part of the parent-child communication is modeling interactive behaviors. And here we have 4 behaviors to encourage. We want to encourage turn-taking, imitation, establishing joint attention, and developing anticipatory sets. Now, I know in the videos from the discussion last week, you saw turn-taking. You saw where James would do something, then I would respond to him. And I was waiting for his turn to respond to me. You saw imitation when he was doing yeah, 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 and I would respond yeah, 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 by imitating his babble, even though it's not real words. Establishing joint attention, you saw Mason pointing to something or trying to draw our attention to James when we were looking at James, or trying to draw our attention to him. So establishing joint attention is when you both focus on one thing. And then developing anticipatory sets. I don't think I had an example of that, but we are playing pea pie with James a lot, and patty cake, and so he's really enjoying that. And so we'll get behind the chair and hide and jump up, pea pie. He smiles and giggles, and then you go back down, and you can see him looking behind the chair, waiting for it, and jump up. He jumps and giggles and laughs because he's anticipating it. He knows what's coming. So for this, the behaviors can be first observed by the parents using videotapes are available, or the clinician can provide models. Effective modeling of turn-taking and imitation, establishing joint attention, anticipatory sets, it first involves being sure the parent is sensitive to the infant's readiness to interact. So they need to be aware of those alert stages we discussed earlier, of when the best time to interact with the child. It's not going to be necessarily an active alert, certainly not in crying, that quiet alert period. So the parent must be prepared to engage whenever the infant signals readiness through a state of alertness, gaze of the parent, and the expression of comfort vocalizations, such as like James was doing, any kind of cooing. So when those signals are perceived, interaction should be initiated. Parents should be reminded that this happens at the time of the infant's readiness. This is no such schedule. We can't say you will interact with your baby at 3 o'clock every single day, because that's not necessarily what the best time is going to be for the baby. We have to follow the baby's lead and guide in this, not the parents. But it can be during typical routine times, such as meal times, diapering, bath time, ordinary daily living routines. James, it's bath time, he doesn't interact so much, but changing table has always been a big place for him to do his communications. His first vocalizations were on the changing pad. As early as a 1 month old, he was sitting there cooing at us. So he really loved that close interaction, I guess, he got when he got on the changing pad and could see our faces close up. Box 6-4 has TIPS, the acronym TIPS. That's take turns, imitate, point things out, set the stage. So you can use that acronym to teach the parents. This is how you remember to interact with your child. Use TIPS, take turns. So coach parents to engage in that back and forth interaction with babies through songs, games like peekaboo, play with toys, Encourage parents to do something baby enjoys. Wait for the child to do something, anything, before the adult takes another turn. Imitation is where the coach families to play monkey see, monkey do, or copycat by mirroring any infant actions or sounds. The parent imitates what the baby does. We're not expecting the baby to imitate the parent at this point. The parent's the one doing the imitating. Point things out is how we establish joint intention. Coach families to engage the baby in joint intention routines by bringing things the child likes within view and monitoring that the child is looking at them before making them move, sound, or operate. Later, when the child is 6 to 10 months old, you gesture or point to establish joint attention to objects at a distance, in addition to bringing objects near the child. And then S, set the stage. Coach parents to establish anticipatory sets by repeating simple games and songs the child likes. If you're happy and you know it, clap your hands. If you're happy and you know it, clap your hands. And it was a great video of Cecile when she's older, not at this stage, but she was doing that on her own because she just loved it. She loves singing. When the child has become very familiar with these, encourage parents to stop momentarily in the middle to allow the child to anticipate and request the next part of the action. So you go, if you're happy and you know it, clap your hands. If you're happy and you know it, clap your hands. And you wait for the child to go, because they're not really clapping like we clap right now, or James claps like this. He claps really fast. I'll have to get a video of him clapping if I can, because when he claps, we'll say, yay! And he goes, big claps. So that's tips on how we can help remember that with the parent. So I read that. And then we want to list the behavior, waiting while the infant performs some behavior, whether it be vocalizing, moving limbs, or making a face. We are looking for anything the baby does as during that turn taking. It doesn't have to necessarily be vocalizations. The McDonald's Eco Program and Appendix 6-7 there's a published program that you can buy that is used to work with parents on developing these tips, skills. And in this, that your turn taking, you want the parents are advised to imitate or match something the child does, then wait for the child to provide a response that the parent can match again, like the yayas that I do with James. And the joint intentional routines, you want to establish joint intention to help baby learn to share focus on topic and elaborate on it. Basis for topic, comment, structure, or conversation later on. So joint intention is very crucial to it's a foundation of our communication skills. It can begin by modeling for the parent how to identify the infant's focus and share attention to that. We can show the parent how to follow the infant's line of regard, look at what he is looking at, and then make a comment about it or gesture toward it. So that's what we're doing with the parents. We're modeling how to do that with them. We can also model the choral vocalization, which is saying what the infant says at the same time he says it, or singing it together. Also can be encouraged as a joint intentional activity. Finally, for establishing anticipatory sets, expectations that actions have been repeated often for the baby will occur in a particular sequence. So the infant gets ready to observe them when part of the sequence is enacted. It's the foundation for the development of knowledges of scripts and schemata. So it's the thought that these scripts help organize knowledge and the acquisition of language used to encode this knowledge. This pleasurable anticipation not only intensifies the baby's interest and joy intention, but also heightens awareness of the sequence, making it more salient and learnable. In other words, because it's so repetitive, that makes it easier for the baby to learn. It also gives the baby a sense of trust and reliability, a feeling of knowing that what can be expected from people. It's important, though, for you as a clinician to determine what games are appropriate based on the family's culture and background. Not all cultures play peekaboo exactly the same way. In fact, when we were playing it with Cecile, we adapted it instead of peekaboo or pie. It was like pizza pie. It sounds like pizza pie almost because of the way she started saying it whenever she started saying pea pie. So you want to find out what the family values and the games they value and build on it from there. Okay. And finally, the developing of self-monitoring skills for parents. So parents need to develop the confidence in their ability to communicate with the baby. So videotape parent for beginning to now progression or self-monitoring. The parent can see the progress that they've made from the very beginning of when the therapy started, or not therapy, I should say more coaching or counseling, to where they are now. They can also see their baby's growth. But that helps the parents monitor, communicate interactions, and the parent to self-monitor. You can review the recordings with the parent and review the interactions the parent's experiencing. Of course, we have to do this in a non-threatening atmosphere, establish an atmosphere in which both the clinician and parent are attempting to learn about what works best for the baby, and rather than one in which the clinician is dictating or even teaching behavior to the parent. In the accepting atmosphere, parents can learn to observe their own and the baby's behavior, determine whether they have made a good match between the two, so the parent's behavior is matching the baby's, or the parent's not matching the baby's behavior, depending on the baby's state, and assess the effectiveness of interactions and modify them as needed. After several video sessions, parents will benefit from watching those earlier videos to see how much they and the baby have grown. And then you as the clinician can use these as an opportunity to praise and appreciate the efforts the parents have made, because they might, being with that child every day, not be able to see a lot of progress every time, but having that beginning to end video, essentially, of this is where you started 2 weeks ago, 3 weeks ago, a month ago, and this is where you are now, this is where the baby is now, they might can see the difference and how their efforts are really paying off. There are commercial programs available, such as the Hanen Early Language Parent Program. The ECO program was mentioned before, the Carolina Curriculum for Infants and Toddlers with Special Needs, and various other curriculums that are available in 6-7. The Hanen program, I don't know if any of you did that through Jackson State. I know that they have in the past, their students were trained in that, and it's been shown to be very effective parent training program in this early intervention settings. And that should do it for Module 3, the NICU and Pre-Intentional Infant.